Good evening, everyone. Thank you for joining us on this lovely Thursday afternoon. And so today we have our presentation on managing obesity. It is truly a treat for me to introduce today's speaker. I have had the great honor of working with and learning from Dr. Chin through every stage of my career for the last 20 years. Dr. Christine Chin is a graduate of 1988 from the University of the West Indies Medical School in Jamaica. She completed her residency in internal medicine at the University of Miami, Jackson Memorial Hospital, becoming board certified in 1993. She successfully passed her American Board of Obesity Medicine in 2017. Dr. Chin is a part of the Healthy Lifestyles team of the Cancer Society of the Bahamas, which leads the charge against childhood obesity in the Bahamas. She's a board director of the Healthy Caribbean Coalition, and as you know, she's a consultant in the Department of Medicine at the Princess Margaret Hospital and a lecturer at the University of the West Indies School of Clinical Medicine and Research. So now let's welcome Dr. Chin to talk to us on obesity.
Good evening, everybody, and thank you, Dr. Black, for those kind words and for inviting me to give this presentation. And thank you all for being here with us. I can't change these slides. Sorry, don't know what happened. Okay, here. I have no conflict of interest to report, and the objective tonight is to discuss the current prevalence of overweight and obesity, to establish obesity as a disease, and to define obesity and discuss the stages of obesity, identify risk factors and complications, and then describe evidence-based recommendations for the management. Worldwide, the prevalence has tripled since 1975. In 2016, we had 1.9 billion adults who were overweight, and about a third of these were obese. In the Caribbean, 1 in 3 children is overweight. And in the US, in 2015, 71% of the adult population were either overweight or obese, and 38% of them were obese. In the Bahamas, WHO and PAHO reported in 2016 that's about the same amount of adults as in the US, about 1% less. So 70% of our adults were either overweight or obese, and about 37% of them were obese. Looking at females and males, 43% of females were obese and about 30% males were obese. That's astounding. And for children, we're seeing more than that 1 in 3 in Caribbean. We're seeing 36% of our children are either overweight or obese, and about 17% of them are obese. When we looked at adolescents, almost 45% of them had a BMI of over or equal to 25. Dr. Dorset Williams showed in 2015 that we're not any better. In fact, we're as healthcare workers, we're setting a poor example. 81% of us were either overweight or obese. And looking at a private clinic in Nassau, 78% of them were either overweight or obese, and about 47% of patients were obese. Looking specifically at nurses, we saw that 60% of nurses, almost 60% of nurses were obese. Obesity is a disease, and we should consider it a disease. It definitely meets the AMA, or American Medical Association, definition of disease with structural abnormalities. There's an increased size of adipocytes. There's dysfunction of the mitochondria and the endoplasmic reticulum, which leads to cardiometabolic and immune abnormalities. And there's associated morbidity and mortality. The AMA finally declared it a disease in 2013, but we know that back in the 1990s, WHO had already considered it a global epidemic. So obesity is a chronic, complex, relapsing, progressive, often lifelong disease. It's a major public health issue with high health and societal costs. Lifestyle modification of diet and exercise is usually inadequate, but pharmacological and bariatric intervention may be required. In terms of the definition of obesity, few would argue that there is an increase in adiposity with whether you're measuring skin fold thickness, waist circumference, or by DEXA scanning, bioelectric impedance, or air-water plethysmography, or by MRI or CT scanning. But by standard WHO definition, most of us use a BMI, which is weight over in kilograms over height in meters squared, greater than or equal to 30 to be obese, and a BMI of greater than 25 or equal to 25 as overweight. So this talk is based on three guidelines throughout the world. There's a 2013 American Heart Association, American College of Cardiology, and the Obesity Society guideline that came out in 2013. And then in 2016, the American Association of Clinical Endocrinologists and American College of Endocrinology came out with their guideline. While in Europe, they published their guideline in 2019. So we're gonna follow these guidelines. The causes are multifactorial. As you know, there's genetic causes, physiological, metabolic, hormonal, sociocultural, environmental, and behavioral causes, as well as psychological causes of obesity. Genetically, we know that people of African descent, people who are Native Americans and Pacific Islanders are very prone to being obese. The rare hereditary disorders of Prader-Willi syndrome and Bardet-Biedl syndrome are also causes of obesity. And we know medical conditions such as hypothyroidism, Cushing syndrome, and polycystic ovarian syndrome are also linked with obesity. Pregnancy, as we all know, aging and menopause are some of the associated things with obesity. When people stop smoking, they tend to put on weight. Some psychological conditions such as stress, anxiety, and depression are also associated with obesity. And certainly medications such as steroids, diabetic medications, and antidepressants, and certain antipsychotics are also causes of obesity. It has been well established that in obesity, there's an imbalance of the various modulators of hunger and satiety with marked leptin and insulin resistance and elevated ghrelin. There are hormones produced in the periphery, adipose tissue hormones such as leptin, adiponectin, retinol binding protein 4 and resistin, and appetite suppressing hormones from the GI tract, like peptide, tyrosine or PYY, cholecystokinin, and GLP-1, as well as GIP. And from the pancreas, the insulin, pancreatic polypeptide, and amylin, as well as hunger-mediating hormone ghrelin, are important afferent signals that bind to receptors in the hypothalamus and the brainstem. Neurotransmitters in these areas, such as the GUT-related peptide and POMC and neuropeptide Y, also play significant roles in the complex and intricate regulation of body weight. More and more research is being done in this realm as more neurotransmitters are being discovered. Manipulation of these peptides or the receptors would be some of the ways where future medications could impact obesity. Many researchers have also looked at the bacteria in the gut, but a recent meta-analysis showed no conclusive evidence that there is any consistent microbial changes in obesity. We also know behavioral aspects of our causes of obesity, including increased sedentary lifestyle, occupation that are sedentary, poor sleep, and alcohol intake. Sociocultural aspects such as parental age and educational level, socioeconomic status, poor appetite, large portion size, and food deserts in the urban areas are also big causes of obesity. And environmental, the obesogenic environment that has fast food and big food, as well as a built environment, are all unfavorable for exercise. And then we have these energy saving devices like smartphones and everything electronic that could cause or link or lead to obesity. So what is the average weight gain per year? About a pound per year in the US, which is just about 10 calories per day, a packet of ketchup. That's all it is that most people are average weight gain per year. And if you were to drink 8 ounces of soda, not even a can of soda, that's an extra 100 calories per day. That would lead to about 8 pounds of weight gain in 1 year. So what are the principles of management? Well, we should recognize that obesity is chronic and quick fixes are discouraged and not sustainable. That weight regain is very, very common. we should focus on health first, not on the scale. So we should become more complication-centric. So it's possible to lose weight and the patient is not healthier. And then the opposite is true, where there is improvement in comorbidities without much weight loss. So we have to set realistic targets of about 5 to 10% of their body weight, because setting unrealistic targets or trying to get them to ideal weight is a setup for failure. Even 5% of their weight loss would lead to a significant improvement in health. We want to identify and address root causes and the barriers of obesity, and we want to see why they're overeating. We want to see if we could increase their physical activity and, of course, recognize that there is reduced metabolic rate at their level of obesity. We want to recognize that success is different for each person, and so we're not going to just target weight and not recognize that you can get improvement in self-esteem, health conditions, energy level, improvement in quality of life, and preventing further weight gain, or just even knowing that a target could be just maintaining the best weight. So that success is different for each person. So how do we approach the management of obesity? We have to improve communication and motivation by using motivational interviewing, or MI. We have to avoid stigmatization, and we should use a multidisciplinary team approach. Try to treat comorbidities as a priority, not the weight itself. We want to assess their weight regularly and measure waist circumference regularly, which is an indirect measure of visceral fat. We want to have them try to prevent their weight cycling and have them definitely have lifestyle behavior change and for them to increase physical exercise. So motivational interviewing involves the 5 A's of obesity. We ask is the first A. We're going to ask for permission. Yes, we're going to ask for permission to discuss weight and explore readiness to lose weight. We want to then assess obesity-related risks and root causes of obesity. And then the third A is advise. Advise on their health risks and the treatment options. And then agree, come to some agreement on the health outcomes and the goals that you're going to achieve. And then we want to assist them in accessing appropriate resources and giving them the names of providers that could help them. So how do we avoid stigmatization for these patients? Well, we've got to recognize that these patients have had bad experience with previous healthcare workers. We have to improve communication by avoiding hurtful, judgmental, critical language and labels. We should try to use terms that are more euphemistic, like unhealthy weight or high BMI, or that you're affected by obesity, or you have obesity, or you have obesity, instead of saying that they're obese or morbidly obese or fat. We have to recognize that obesity is a disease and that the weight is not fully under a person's control, or it's not their fault. And we got to maintain a positive, constructive, and trusting relationship. So Dr. Derwin Johnson in 2018 and his group showed that we have a lot of weight bias and stigma in the Bahamas. Almost 90% of our physicians had some aspect of stigma against obese patients, and we rated moderate on the anti-fat attitude scale. That means that 90%, 9 out of 10 of us have a problem with fat people. So we have strong implicit and explicit bias in doctors here, as prevalent as in the general population. And that's troublesome because most of us are obese or overweight ourselves. So we see that as BMI increases in patients, doctors report that they have less patience, less desire to help, they have less respect for their patients, they think that the patients are wasting their time and they get very frustrated, right? So patients are viewed as being less self-disciplined, less compliant, more annoying to them. And what about on the patient's side? Well, they think that we're judging them negatively, probably true, right? That we lack empathy, that we get upset, they get upset by our comments about their weight, and that we're blaming their weight for all their problems. Patients feel judged. Patients who feel judged have lower trust in us, and of course, they're gonna definitely be more reluctant to discuss their weight concerns. So what are the consequences of stigmatization? Well, they'll have low self-esteem more than they would normally. They also have poor body image. It also could lead to more eating disorders like binge eating. They're going to avoid exercise. They're going to avoid doctors or try to shop around till they find the right doctor. They get more and more depressed. There's further weight gain, weight cycling, we call it. And then some of them might even consider suicide. What about the personal attitudes of these doctors? We unintentionally harm the quality of our relationship with patients. So we have to be aware of our own body language, our gestures, the way we sit with our patients in terms of distancing, spatial distance. We need to be aware of our eye contact, our facial expressions, and the tone of voice. So we need to improve our communication by using motivational interviewing, using non-judgmental collaborative discussion, reinforcing the patient's own motivation, stimulate their involvement towards change. We have to have a pleasant, warm, mutual trust with empathy and encouraging without any bias to try to promote confidence in the patient. So I'm really concentrating on this or spending a lot of time on this because we need to get past this. 90% of us have a problem with overweight patients. So some of the useful questions that you might want to ask the patient is, may we talk about your weight? How important is it for you to change your behavior now? How confident are you that you can make a change in your lifestyle? Are there any stressful events in your life presently that could be a barrier to change? What changes in your lifestyle would you make? What happens when you feel stressed or sad or bored? What weight loss goals would you set? What kind of physical activities do you enjoy? And what kind of help would you like? So we're going over the top part of this with the communication. We're going to go to doing the medical evaluation next. And then after that, we speak about treatment. So the second A is assess. We're going to assess obesity-related risks and root causes of obesity. So we have to spend a lot of time taking history, specifically weight history and specifically the milestones. So we want to know what they were at childbirth, how much they weighed during childhood and high school, college, and what happened when they got married. Most people put on weight, but then they may have gone through divorce. So we have to assess that as well, and pregnancies, unemployment, or any other significant events that might impact their weight. We have to explore reasons for their weight gain, whether it's the pregnancies or certain medications, and we've already listed some of those, but there's lists on the internet that you could look at. Psychological issues like depression, anxiety, and stress are also problems that we need to look at. We need to see whether they had stopped smoking or stopped other types of habit that cause them to put on weight. Let's look and see if they have any eating disorders like bulimia, hyperphagia, or night eating. Or was there an injury or some other cause of their decreased physical activity now? And then we're going to look at their evaluate prior treatments. So in terms of what types of diet were they on, what were the effects, what kind of physical activity were they doing during that period, and what were the reasons for their failure or regain of weight? What were the positive points they found in that particular time of weight loss? And were their friends and family supportive during that time? Okay, looking at meals and eating behavior, we have to see what they're eating. So yes, they should be writing down a diary on how are they eating it and with whom and where. Are they eating while watching TV or using their smartphone or some other device? Are they home or elsewhere? And we have to know what the composition of their meals are, what the portion sizes they're having, what type of desserts and snacks they're eating. Is it home cooked meal or is it purchased outside? Lots of fast food going on. Do they drink alcohol? What type and how much? And sweet beverages, how much and what kind of drinks are they drinking? And do they eat more when they're happy, sad, depressed, or bored? And why do they eat? Do they feel hungry often? Are there any cravings? Are they addicted to certain foods? Do they binge eat? And are they putting the snacks in front of them at night while they're watching TV? Okay, so we're gonna have to look next at the psychological aspect in terms of their body image, the psychological impact of the weight on them, what is their self-esteem, we have to estimate that, and then speak about what their desired body weight and image is, just trying to assess their degree of motivation for treatment or change, and see what type of weight loss they expect to lose and where do they want to go with their waist circumference. The other history that you want to ask about is lifestyle history in terms of their occupation. What kind of work do they do? What are the family dynamics? And then what kind of physical activity are they engaged in? And do they enjoy any hobbies? All right, so we're coming on to physical examination. So here is where you need to be very discreet. Obviously, you're going to try to do it in a private space. They're going to get very embarrassed. So you're going to obviously measure their weight and height and calculate their body mass index, do the waist circumference, and check their blood pressure with a proper size cuff. And this is where it comes into that we have to have the proper bariatric equipment. So you have to have proper size chairs and exam tables and not have them be embarrassed about trying to fit into a small chairs. And then we're going to look for signs of comorbidity. All right, so just want to talk a little bit on longevity. We know that when patients are overweight, it shortens their lifespan by about 2 to 7 years. And then when they get more and more obese, and with a BMI of 30 to 39, as much as 10 years could be taken off their lifespan. And then when they become morbidly obese, they're up to 20 years have been lost or can be lost. All right, looking at a different way, BMI was found to be inversely associated with overall mortality. So if a patient has a normal BMI, they have an 80% chance of reaching the age 70. When the BMI becomes between 35 and 40, they have a 60% chance of reaching age 70. And certainly by the time the BMI goes over 40, only 50% chance of reaching age 70. And then when you share this with your patients, they will be shocked. And so I use some of this data to tell them, about obesity. So BMI alone does not provide sufficient evidence to implement policy or individual intervention. So coming out of a consensus conference on obesity in 2014, the AACE, or the American College of Clinical Endocrinologists, and the American College of Endocrinologists added a clinical component that better describes the status of a patient so that proper therapeutic intervention could be initiated. So be aware that they use a BMI of 25 as a cut point for this staging criteria. So normal weight is when the BMI is less than 25. Stage 0 is a BMI of anything over 25 with no complications at all. And stage 1 is when they develop some kind of complication, but it's a mild to moderate obesity related complication. And still the BMI is only 25 or over. Stage 2 is when the BMI is still 25 or older, but they have one or more severe obesity complications. And I just want to add that their severe complication is even pre-diabetes. It's metabolic syndrome or diabetes or severe physical activity, while a mild to moderate obesity complication is controlled hypertension. When the pressure becomes too high or it becomes difficult to treat, they fall into stage 2 obesity. This association also coined the euphemistic term adiposity-based chronic disease, ABCD, to be used instead of obesity, so as to lessen that stigmatization effect of the term obesity. So we could use ABCD. Sorry, Dr. Halliday, there's some markings on my screen. I don't know where they came from. Are you seeing them? Hello? Huh? Okay, so obesity is a risk factor for complications and comorbidities. So we know for sure that it causes cardiovascular disease. It's linked with type 2 diabetes, many types of cancers, deep vein thrombosis and pulmonary embolism and osteoarthritis, but it also causes gastroesophageal reflux disease, cognitive mood disorders, as well as obstructive sleep apnea. So those are some of the big ones, but we know that it causes everything from the head to the toe. such as intracranial hypertension. We know it causes fatty disease, and now cirrhosis. The number one cause of cirrhosis in North America is now fatty liver disease. We know it causes or is linked with gallstones, abnormal menstruation, infertility, polycystic ovarian syndrome, and it could cause complications in pregnancy. We know it's linked with gout and compressive nerve problems. And we know obesity also causes more cancers, as we mentioned before, and pancreatitis, and of course, the cardiometabolic problems. The top 7 diseases in the Bahamas and in the Caribbean, which is hypertension, diabetes, heart failure, stroke, kidney disease, hyperlipidemia, and certain types of cancers like breast, prostate, and colon are all associated with obesity. So somebody's putting all kinds of things on my slides. Where did this arrow come from? And these markings, are you seeing that? Anyway, so we go on to laboratory investigations. We should do the first 5, which is fasting blood glucose, A1C, lipid profile, liver function tests, kidney function tests, and thyroid stimulating hormone on all patients who are overweight or obese. And you might want to do inflammatory markers such as CRP, C-reactive protein, or ferritin. Uric acid can be done for those patients you suspect gout, polysomnography for patients with obstructive sleep apnea, and echocardiogram if you think they have heart disease. And of course, you do an endocrine workup if you're suspecting Cushing's or hypothalamic disease. All right, so besides diagnosing other comorbidities, you have to evaluate for metabolic syndrome, because metabolic syndrome, as considered by the ACCE, is a severe complication. So the International Diabetic Federation criteria is a waist circumference of greater than 94 centimeters in males, greater than or equal to 94, or greater than or equal to 80 in females. And remember, for Asians, we have, it's less for us, so it's 90 centimeters for males in Asians. And 2 of the following: triglycerides more than 150, or HDL less than 40 in males or less than 50 in females, established hypertension or blood pressure greater than or equal to 130/85, or diabetes, established diabetes or glucose of greater than or equal to 100. So after you've evaluated the patient and assessed all the risks and root causes, then you're going to advise on the health risks, the treatment options, and long-term strategies. So the management of obesity starts with, 1, at the very base is lifestyle modification for everybody who's overweight, using diet, physical exercise, and behavior modification, and then drugs if the patient meets stage 1 obesity, or if you're using the European guideline or the American Heart Association guideline, it's BMI over 27, greater than or equal to 27, with comorbidities, or just being obese without any comorbidities. And then bariatric surgery should be offered for those patients who are BMI of greater than or equal to 35 with comorbidities, or a BMI of greater than 40 without comorbidities, or stage 2 obesity according to ACCE. So the American Heart Association, American College of Cardiologists, their TOS recommendation is high intensity, comprehensive lifestyle intervention, which includes a moderately reduced calorie diet, increased physical activity, and behavioral strategies, with at least 14 in-person sessions in 6 months. This is the most effective behavioral weight loss treatment, and we could get about 8 kilograms weight loss with that.
There's a cervical pin.
Sorry. The alternative to this high intensity therapy would be an intervention delivered electronically by internet or telephone with personalized feedback, with or without the use of pre-packed meals. Or instead of that, you could refer to a nutritionist. So it doesn't matter which diet is followed. Weight loss occurs if there's adherence to that diet, whether it be Weight Watchers, Jenny Craig, the Atkins, Ornish, Volumetrics, or the Zone diet. We get about a 6 kilogram weight loss, and recognize that these diets can't be sustained for long term. So we should really be advising a healthy diet. So we want to utilize the services of the dietitian or the health educator. We want the patients to be monitoring themselves every day is the best way of weight and calories. So they should be using a food diary, a food journal to monitor their calorie intake and the calories that are being burnt every day. Then we should be pushing a 500 to 750 calorie deficit per day. So for women, that's about a 1,200 to 1,500 calories per day, or for men, 1,500 to 1,800 calories per day. And of course, you adjust that for each individual. And apps like MyFitnessPal from Under Armour would be helpful as well. All right, in terms of the eating behavior, you want to re-educate the patient to appreciate the act of eating. So they should be eating at the table with no distraction, no TV, phone. They should be eating very slowly and mindfully, taking about 20 minutes to enjoy their food, chewing carefully, enjoying the smell, the taste, the texture, the flavors, and the temperature of the food, savoring and enjoying each morsel to satisfy satiety, and to observe their emotions while they're eating. You want to advise them to take in less energy-dense foods, less fatty foods, and definitely less saturated fat, less refined carbohydrates, especially straight sugars and sugar-sweetened beverages. We want to have them eat more vegetables and fruits from a smaller plate and in definitely smaller portion sizes. We have to advise them to avoid skipping meals or having frequent or unhealthy snacks. We want them to avoid buffets and family-sized meals and to stop eating when they're not hungry. We want them to stop eating even before they feel full. And the Japanese has a saying called hari hachibu, which means that you should stop eating when you're about 80% full. How about drinks? Let me grab a glass of water. We want to advise them to drink their 8 glasses of water per day. And that means drinking a glass of water before they eat or their food in front of them, and to drink water while they're eating. So we got to kind of do the opposite thing that our mom used to teach us. We want to avoid having them drink so much juice. So a glass of orange juice is equivalent to about 4 or 5 oranges. Now, none of you would sit down and eat 4 or 5 oranges straight off the bat. So I would prefer you have your orange, 1 orange or half an orange, and then drink your glass of water. The other thing about diet sodas and drinks made with sugar substitutes is that they're substitutes for those sugar sweetened beverages, but if they're used to drinking a lot of these sweet drinks, they're gonna not be able to change the sweet taste of their mouth, and they always want to have sweet drinks. Just one point here is cutting back on 3 sweet drinks per day. It would be equivalent to losing a pound a week. So that's one quick, easy way to lose weight. Now you should recommend an 8-inch plate, and half of the plate should be vegetables or fruits. The other quarter of the plate should be protein, which could be beans or peas or lentils. It doesn't have to be animal protein, and that should be about 3 ounces of protein. The other quarter of the plate should be carbohydrate, which would be rice or yams, potatoes, pasta, or breads. And on the outside ring of the plate is the snacks. So they could have fruits or fat-free milk or yogurt or nuts. So the nuts, they should restrict them to no more than 3 handfuls per week. Look at this plate. So this is an 8-inch plate versus a 12-inch plate. It's the same amount of food in each plate, but this definitely looks like a lot more food, and that looks like very little food. So really advising smaller plates would help psychologically in terms of the viewer. Okay, let's go on to physical activity. Here we would want to utilize the expertise of a personal coach or exercise trainer, even occupational therapist or the physical therapist, because we know that regular exercise decreases visceral fat, so there's less risk for comorbidities. 300 minutes per week of moderate exercise is equivalent to about 150 minutes of intense exercise, and that's sufficient to mobilize visceral fat. 10-minute segments are acceptable, so a good thing would be to tell your patients to, or ask your patients to move around after eating. Yes, after eating, after each meal. So that's the 30 minutes right there every day. Metabolism slows down with weight loss, so we should increase our physical activity as the patient loses weight. Okay, this is where I want to show you how much physical activity is needed to burn off a little of your favorite foods. A single M&M, yes, one single M&M or a single potato chip, we'd have to walk about 100 yards, the length of a football field. A can of soda takes about half-hour walking to burn off. And for a slice of pizza or a medium fry or 2 ounces of potato chips or a Snickers bar would take an hour of walking. And for a nice hot juicy Cinnabon, about 2 3/4 hours of walking. Yes, that's a lot of time to exercise for just one Cinnabon. So think about, or you kind of weigh those for your patients. And a hamburger meal with fries and soda would take 3.5 hours to burn off those calories, about 11 miles. So now I want to show you that exercise doesn't add much weight loss to the dietary changes, which is in orange here. So you get about 8 kilograms of weight loss with diet alone. And when you add exercise to that, we see an additional 3 kilograms, which translates about 1.5% of weight loss, 1 to 1.5% of weight loss. So it's not a major weight loss change that we're looking for. So we're promoting exercise not to lose weight so much as for the cardiometabolic benefits and to reverse the slowing of the metabolic rate when patients lose weight. How about the psychological aspects? Well, here's where we need the help of our colleagues, the psychiatrists, psychologists, behaviorists. We know that psychological aspects strongly influence success and that patients have an emotional relationship with food. We know that depression and anxiety is very high in our patients. So psychiatric or cognitive behavioral therapy can be used for eating disorders. And we see that body image, self-esteem, and self-confidence improves with psychotherapy, whether it be individually or with group therapy. We know patients who have inadequate sleep, time deficiencies, and stress all add to or contribute to their driving force for obesity. So we need to correct those. We need to advise that they have their 7 to 8 hours sleep, that they manage their time properly or appropriately, and that we develop coping mechanisms that are not food related for them. So that's the bottom of the pyramid with lifestyle modification. We're going up this, the pyramid to pharmacotherapy. Remember, those are for patients who have a BMI of greater than or equal to 27 with comorbidities, or just a BMI of 30 or over with no comorbidities, or stage 1 obesity according to ACCE. The target would be 5% weight loss in 12 weeks. And if they're not successful, then they should stop the medication. You all might know liraglutide, which is a GLP-1 agonist that slows gastric emptying and increases the feeling of satiety. The brand name is Victoza for diabetes, but it's also marketed as Saxenda for weight loss. It has to be given subcutaneously, and one of the biggest side effects are nausea and vomiting, which may contribute to that weight loss. Losartan or Belviq activates the serotonin receptor in the hypothalamus, thus promoting satiety. However, it was withdrawn earlier this year in February because of an increased risk of all types of cancers. Contrave is the combination of naltrexone and bupropion or Wellbutrin. So you know that is an antidepressant, and this is the addiction medication. It helps to reduce hunger and to control cravings. And I'm sure some of you, like myself, would have used Orlistat before. It is by prescription as Xenical and half the dose as Ally over the counter. It blocks lipase in the small intestines so that patients get this explosive diarrhea when they eat fatty foods. And at times there's that embarrassing leakage as well. So none of my patients stayed on it long enough to derive any benefit from it. That last medication is Quizmia or phentermine and topiramate. This is approved in the US, but is not available in Europe, Canada, UK, or Australia. Phentermine suppresses appetite, and topiramate, is used for seizures and for prevention of migraines, and that's linked with weight loss. In the Bahamas, only Orlistat or liraglutide is available or was available for treatment of obesity. Last time I checked, I couldn't find any stock of Orlistat here. So let's look at what the weight loss is for these medications. For Quizme, we get about 21 pounds. For phentermine by itself, 16-pound weight loss. Contrave gives 14 pounds. Saxenda, 12 pounds. Belviq, which is withdrawn, about 8 pounds. And Xenical, 6 pounds. So between us, 5% to 7% weight loss. Which is it that effective or not? Is there any things that show that it's effective? So in clinical trials evaluating these medications, up to 56% of patients were unable to achieve 5% weight loss. And in a meta-analysis of these trials, only a mean of 3.5% after 3 years was reported. And then weight gain was seen in a majority in all studies. So the anti-obesity medications is limited and expensive. Most of them are unavailable in the Bahamas. There's lots of contraindications and adverse effects and very little weight loss with much weight regain. And then the long-term experience is lacking. So there is limited use of these medications. Okay, we reached the top of the pyramid with bariatric surgery. And these are for patients who have a BMI of 40 or over without any comorbidities, or if they have a BMI of greater than or equal to 35 with a comorbidity or stage 2 obesity. It's shown to reverse or improve comorbidities. It's shown to improve self-esteem. Bariatric surgery also improves fertility, and it's associated with less complications during pregnancy. There is less cancers reported, as well as increase in long-term mortality. So what are the 4 surgical procedures? About 50% of the procedure in the US is the gastric sleeve. It's the simplest, or one of the simplest procedures to do. 42% of patients have the Roux-en-Y procedure. And then the other 10% of patients would either have a gastric band or a duodenal switch. So in this meta-analysis of the bariatric surgery, they've shown about 65 to 70% of patients will have some improvement or even reversal of their hypertension, the diabetes, or hyperlipidemia. So we know that bariatric does work. And it's shown to have 33% lower hazard ratio of developing any cancer, with reduced risk of breast cancer, colon cancer, endometrial cancer, and pancreatic cancers. So the benefits of bariatric surgery are well established. We could shave off about 10 to 20 units of BMI, but there is a high cost attached to it. There's high risk and a lot of complications. Patients have to make major dietary adjustments, and they need to take a lot of supplements, minerals and multivitamins, and many, up to 40% of them, will regain some weight. So bariatric surgery is not amenable to the majority of patients. All right, so we'll go on to the next two A's, which is agreeing on health outcomes and behavioral goals and assisting them. So we have to agree on a SMART plan, and a SMART plan we mean by that is S for specific, measurable, A for achievement, R for rewarding, and T for timely. So we gotta get simple steps, simple goals, and assist by addressing them by addressing the barriers and the drivers of obesity, educating them, all that we spoke about before, and giving them resources, whether it be online, on the internet, or by literature that you're gonna print for them and give to them. And then appropriate referrals to the consultants that we spoke about. And then you wanna follow up, arrange follow-up visits for them. So I just want to show you these extensive algorithms. This is the AHA, ACC, TOS algorithm. I don't expect you to go through that, but we just went through all of that just now. And this is the ACCE and ACE algorithm. That's a little bit simpler to use. And then the European algorithm. So we went through all 3 of them just now with you. So what are we looking at in the future? Well, PYY, GLP-1, GIP, and synthetic leptins are some of the things that they're looking at. They're looking at putting them all together or combining some of them, like GLP-1 with glucagon, GLP with GIP, GLP-1 with the 3 of them put together, and then trying to surpass the parenteral routes and making them as tablets. So although this focus of this presentation was on managing obesity in the individual patient, I would be remiss, completely remiss, if I didn't mention the obesogenic environment and what the Healthy Caribbean Coalition is advocating in the Caribbean. Much of these points that I have here were taken from their website. As a sidebar, I just want to mention that obesity, or global obesity, what they now term as globesity, yes, globesity is a term, adds 20% more greenhouse gases production, all because of increased food production and consumption, as well as manufacturing larger items for people, but also in terms of transportation. So cars, trains, and planes obviously are going to be using more fuel. So going back to the obesogenic environment, the HCC and what we should be pushing for and advocating for is to prevent kids from becoming obese. We have to encourage breastfeeding in our population. We want to ban marketing of sugar-sweetened beverages and unhealthy foods to children. And we want to ban the sale of the same items in and around schools. We're looking at packaging labels and trying to get them to put them on the front of the package that are, and having them have, like stop signs so that people know that, like, when these sugars are so high, it's actually like a red light, and that things are easy to understand. People are able to appreciate and recognize when things are not good for them. We want to have the government tax sugar sweetened drinks and unhealthy foods like chips and certain fast foods, and try to lower taxes on healthy foods like fruits and vegetables. We'd like to educate our public more and the school children about weight and nutrition and physical activity. And we want to promote physical activity by increasing PE in schools and activity during regular classes, but also during break time and lunchtime. We should push for duty-free exercise machines and bicycles. I know here in the Bahamas, bicycles are now duty-free, but we want to promote bicycle lanes, or for them to provide bicycle lanes for us, as well as public parks, more public parks, and more workplace gyms. We should also encourage healthy eating with more plant-based meals. Right now, with the lockdown and with COVID pandemic, yes, that's the first time I'm mentioning the pandemic tonight, but yeah, we're pushing for backyard, or promoting backyard gardens, and I see that the Ministry of Agriculture is doing their part in that respect. We also want to change the items in the bread basket, as Dr. Sands had wanted to do when he was minister. And then we need to make changes in the fast food and the big food industry. So this is the last slide, and thank you for going through this with me. These are the take-home messages. That obesity is a highly prevalent, yes, very highly prevalent, and most of us as healthcare workers or healthcare providers are one of the biggest people in the Bahamas. It's highly prevalent and it's a chronic problem, so we have to keep on with our patients. We have to realize that it decreases life expectancy and causes numerous diseases. We need to eliminate stigmatization, and we need to realize that the management of obesity is complex, continuous, and individualized, and that diet and exercise are the foundation of this management. Pharmacotherapy, as you see, is not very effective, and bariatric surgery is not easily accessible or desirable. So I thank you for your attention, and if you have any questions, you could ask Dr. Google. Thank you.
Thank you very much, Dr. Chin, for such a timely presentation. So we do have some questions, and moving along with how you highlighted that obesity is a problem even in our own profession, we have a comment from Dr. Avril, and her concern is that how do we reconcile our advice to patients about not skipping meals, drinking water frequently, and all of these good habits with our culture as physicians of long work hours with no official meals or snack breaks or breaks of any kind. It's definitely a challenge to practice what we preach.
Right, so skipping meals, so some people have shown that skipping meals and doing that intermittent fasting might be helpful for some people. And for most people though, skipping meals isn't a good idea because they tend to overeat at the next meal. But definitely, I agree with her, Dr. Avril. Thank you for
Yes,
that.
and so there is a question that ties in to the skipping meals, as you just highlighted, from Dr. McPhee. As some research shows, intermittent fasting can have a positive impact on hormones such as ghrelin and insulin. And what role does intermittent fasting play in weight loss? Or do you recommend it as a part of
Mentioned
your
that it depends. Some people are able to do it and some people aren't. So for those people who it does work for, then I would suggest they continue using it. For people who do it and they're not losing weight, then we need to find another option.
What are your recommendations with regards to the keto diet to which patients could practice this to be most harmful? To which patients could this practice be most harmful?
Right. So, so for those patients who have diabetic problems or metabolic changes already, you might not want to use that particular diet. But as I told you, all the diets, once they are on that particular diet, whatever diet they use, they're going to lose weight. However, a keto diet isn't sustainable. So even though they take it for a couple of weeks or months, it's not sustainable. So I suggest they could use it for weight loss, but then they should be on a healthy diet and we should transition them to a regular diet, a regular healthy diet.
Okay. And have you found a particular approach that seems to work better for managing nighttime eating?
A better what? Sorry, or a better way of managing?
Have you found a particular approach that seems to work better for managing nighttime eating?
No, I don't. But I think the biggest thing is not to buy the snacks. People tend to buy snacks and not realize that they have them there and then they have them ready in front of them, like while they're watching TV or right by their bedside. So don't make it very easy for them. So try to not even buy the products. But then using psychological help, it's hard.
And Dr. Bassett wants to know, what role does metformin have in non-diabetic obese patients?
Right. Well, we know that it helps with weight loss and we know it helps to prevent diabetes from occurring. So yes, for some people, you might want to choose metformin.
Okay. And what about the microbe role in obesity?
Right. We mentioned that there was a meta-analysis study in 2018, which showed that there wasn't any particular specific bacteria. So there's no consistent conclusion.
Okay. And do you have any comments on obesity in menopause?
Yes, we know that in menopause, that increases the risk of obesity. Going through menopause, definitely they have a weight gain during that time.
Okay, and Dr. Shrikant has actually contributed an article for us to look at on intermittent fasting, and the link is there in the chat for those of you that might be interested.
That's great. Thank you.
From Dr. Hunt Burrows, in addition to increased physical activity, patients need to be educated about the gains of interrupting prolonged inactivity. Get up intermittently and move, particularly helpful, especially now during this period of lockdown.
Oh, always, right. So for even my sedentary patients, we try people who are at the desk, they should be getting up every 15, 20 minutes, even just for a walk around the desk or anything. And that's why even after meals, we're trying to get them to move for 10 minutes after meals, just to walk around.
Okay.
Dr. Hunt, I appreciate that.
And then Dr. Farquharson wants a little bit of clarification on metformin. Can it be used as a weight loss tablet? Any consequences?
Right. So some people have used metformin for weight loss. It's not a very good weight loss medication. It tends to stabilize after losing 2 or 3 pounds. So it's for the most part, we don't use it for weight loss. We use it for the metabolic changes we get.
Okay, and so, one of our final questions, you highlighted when you were doing the interviewing with the patients that you need to identify why a patient's overeating. From your experience in interviewing patients, do patients feel that they're overeating?
They don't recognize that they're overeating, but so you have to actually go back and look at their diary. So that's where the food journal really, really helps, because one day they'll be very, very good at the 1500 calorie diet, and then the next day they're eating 3000, double the amount. So you really have to look at what they're eating and seeing what's going on, and they're not recognizing that. No.
And from your experience in practicing obesity medicine thus far, what do you think are the greatest barriers to weight loss in the Bahamas?
Everything, our culture, one. Two, the obesogenic environment. We got lots of fast food. And I don't know if you were out yesterday, but one Burger King was open and the crowd or the car lined up for all that fast food is amazing. It was wrapping around the road a couple of times and causing traffic. But yeah, it's everything. Our diet in the Bahamas, we don't exercise enough anymore. It's a lifestyle, everything's easier. All the above that we spoke about in the last hour.
And so Dr. Shamanique has also posted the link to an article on menopause and weight for those of you that would like to read a little bit more about it. Dr. Curling, many patients think that their weight is perfectly fine. How do you address this issue? Solid is beautiful.
Right, and we took a look at that study in our patients before, where we found that most of them realized or didn't know that they were overweight or considered to be obese. But it is a cultural thing, and that's the hard thing to fight. Remember, we're not thinking about having them lose weight so much as to be healthy in terms of reducing their comorbidities. So if that involves losing weight, yes, but also to think that you can be overweight and still be healthy. In fact, a person who is overweight and fit is actually better than an unfit person with normal BMI.
And tying into that, Dr. Ashley says patients with eating disorders tend to deny, deflect, avoid. Are there any psychological resources available locally for patients with eating disorders?
Not that I know of, but our psychiatrists are there for us to assist us for sure. But specifically one person, no, I don't know if anybody who's expert in that.
Okay, we have lots of questions.
But some people could jump in and help me out if they know of other people who are, more people we have on board to help us with fighting obesity, the better.
So can one of the obesity medications that you mentioned here be used to replace metformin in patients with PCOS?
Good question. You could try the liraglutide, which is the one that we have here, and ALA. You could combine them as well, but we don't have the other three.
Okay, and from Dr. Shamanique, what are your thoughts on alternative medicine and weight management, herbal supplements, acupuncture?
I don't have enough information about that. I see a lot of people are pushing prebiotics and probiotics and multivitamins, but I don't think there's enough information out there for enough studies done on them.
Okay,
and we talked about the meta-analysis of the microbes, right, in the gut, and that's what the prebiotics and the probiotics are supposed to do, is to change back the gut flora. But that's not consistent. We haven't seen a good study on that.
Okay, and Dr. Valentine Grimes, is there a role for improving metabolic profile in patients who are within the normal range? Example, thyroid hormone.
You mean to give thyroid hormone to somebody who has a normal weight?
Is there a role for improving metabolic profile in patients who are within the normal range? I think it might be meaning normal range of thyroid hormone.
Oh, no. So no, that's not recommended at all to manipulate our hormones. No, not to use thyroid hormone at all. No, it's not recommended.
And to go back to the question that Dr. Alec asked about an alternative for metformin in PCOS, he also asked, would there be a better outcome with the medications you suggested?
I don't know. I don't think, I haven't seen a study on PCOS specifically with those medications. We know for sure metformin works for them, or in some regard, but I don't know if there's any studies out, or I could look it up and come back to him. on that.
And Dr. Varunda has a comment. There's an interesting BBC documentary, Men Who Made Us Fat. She recommends watching it. So during the lockdown, some of you can have a look at that.
Right, I haven't looked at that one, so I definitely watch that one. There's many of them about plant-based foods and about animals and about obesity. Yes, that should be watched, and many of them are around.
Okay, and from Celine, is there a program in the Bahamas to help guide persons who are overweight or obese, nutritional plans, exercise plans, etc.?
Come again, I didn't hear you.
Is there a program in the Bahamas to help guide persons who are overweight or obese, nutritional plans or exercise plans?
There is, everybody has their own little thing going. So there's many nutritionists out there and lots of fitness gurus who can help you with that. But I don't think there's any one place to do everything all in one spot.
Okay, and Dr. Frankson would like to know, how does allostatic load relate to BMI?
I don't know what he means by that. What does he mean by that?
Dr. Frankson, can you unmute your mic and probably let us know what you mean by allostatic load?
I'm not familiar with that term. Sorry.
Okay, so while we wait for Dr. Frankson to unmute, Dr. Desdemona Downs has said that psychiatric evaluations can be accessed through normal channels, private psychiatric clinics, offices, SRC, CCAC. They work in tandem with psychologists in both arenas to first diagnose, then develop treatment plans to address the issues.
Right.
And Dr. Dorset would like to know, can you comment on meditation, mindfulness, and relaxation in obesity management?
Those are definitely helpful. You would want to encourage that because that would help to dampen the anxiety and the depression problems, all the psychological issues that they have. So definitely would be helpful in that regard.
Okay, and Bertha Sands would like us to know that there's the Healthy Lifestyles program as well. From Dr. Humes, what is
Where is that? Sorry.
Sorry?
Where is that?
Healthy Lifestyles program. Bertha Sands, can you unmute your mic and let us know a little bit about the Healthy Lifestyles program? I'm not too sure that the participants are actually able to unmute their mic, but if
yeah, Darren Holiday has to do that. Okay, can you unmute?
Can you let me comment on the allostatic load issue now?
Yes, go ahead, Dr. Frankson.
Allostatic load is really related to stress and the extent of wear and tear of the body as it goes through. For different people having different levels of stress, does that in any way relate to a person's body mass index?
Oh, for sure. Didn't we show that before earlier about stress and anxiety and all the psychological issues that could contribute to obesity? They're all driving factors, all drivers.
Okay.
Sorry. Maybe you just want to comment on that and give some of your input?
Well, in the United States, what they noted was that the poorer you were, the more likely you were to have a greater allostatic load. Yeah. And also the more likely you were to have an increased BMI. And, and also the comorbidities that ended up as a result of that. So I just wondered if, to what extent you thought about that, and do you think that it relates to, say, our setting here in the Caribbean and the Bahamas in particular?
Well, we did mention that socioeconomic status impacts obesity. We did. All right, Dr. Humes had a question about my experience with patients who've had bariatric surgery. I've had a few patients and they've lost, over 100 pounds. and they've actually reversed their diabetes and hypertension. But since then, they haven't come back to me. One particular patient died with complications of intestinal obstruction. So yes, those are the two patients that I had at bariatric surgery, major bariatric surgery. Some patients have had other types of surgery, but those are the two big gastric bypass ones.
And Dr. Moxie, what do you see the impact of COVID-19 will be on NCDs, including obesity in the Bahamas? And what solutions can we offer as physicians?
Right. We know throughout the world right now that COVID has caused and has impacted obesity and on the non-communicable diseases in many ways. So we're now more sedentary, we're getting more food, we're eating more at home, but we're also not seeing our patients. So the non-communicable diseases aren't appropriately controlled. And so yes, there are more problems.
Okay, and I think we've come to the end of our questions. Dr. Shrikant has put in the chat what the definition of allostatic load is for those of you that are interested. And the wellness program that Bertha Sands is speaking about is 8 weeks to wellness at Bertha Sands. Let's see, we have one more question. PCOS patients may use anti-obesity meds instead of metformin to help with weight, but cost and availability is a limiting factor. So it's not really a question, but it's a comment from Dr. Chamonix.
Right, correct.
Okay, there's one question from YouTube, and this is from Cipriano Strawn, who is asking, you mentioned Cushing syndrome earlier. Do you have any suggestions with
I mentioned what? I'm sorry?
Cushing syndrome earlier. And
Right.
the question is, do you have any suggestions about how to manage or to help with the obesity associated with that?
No, but if you treat the Cushing's, the obesity gets better.
Okay, well, thank you very, very much, Dr. Chin, and thank you to all of you for participating, all 200 plus of you. Dr. Beverton Moxie, excellent presentation. Yes, thank you very much, Dr. Chin.
Thank you so much for having me.
And just to remind everyone, you do need to go to the university website, Sunshine Learner, which has been posted in the chat and has been posted in your notice, to do the feedback link. And I recommend that you do it as soon as possible because there will be some feedback questions pertaining to the presentation. And so the sooner you do it, the better it is. Dr. Mortimer Moxie, can we have the presentation? The whole thing has been recorded and it is available on the Sunshine Learner website. So yes, you have access to the presentation at your convenience to peruse and look over as you need to. Please remember our CME schedule is fixed. It's the second Wednesday and the last Friday of every month. So you can look forward to the next presentation on Friday the 28th. The notice will go out in the next few days. Once you do your CME evaluations and the CME credits become available, you should receive your certificate sometime between October and December of 2020. Yes, we will post the link one more time for those of you that are asking for the link. So thank you, everyone, and have a good evening.
Thank you again. Thanks so much. Have a good night. Bye, everybody.